Hey, good afternoon to all. Thank you, Orakan, Amitabh, Dr. Belli, and Suresh for joining us this afternoon. I have my team here. Introduce my team. Dr. Sanktivel is my colleague, and we have been involved in valve implantation. She's on the right side. And we have the anesthetist, Dr. Basant Ruben, and we have technicians and other nursing team here. So, quickly going on to the patient, to the history. Can you show the slides, please? Okay, so a 13-year-old boy was diagnosed of heart disease 7 months of age, for which he had a transanular patch tetralogy valve repair, and then he's been on 3.5 years of age, and he had has been under follow-up, and he had 2 to the episode of syncope. But if you look at the history, is more related to like a vasovagal. But when we looked at the Holter, he had occasional ventricular couplets and triplets, so we put him on atenolol. Next slide, please. So basically, this is a child who's got symptoms, and QRS duration is about 140 to 150 milliseconds. Sinus rhythm. Next one, please. Okay, so Bharat, you can see that's a severely dilated RV with mild to moderate dysfunction is there. Next slide, please. You can see there's some monocus valve. What the surgeons have put in, you can see that they're hanging around the LVOT and causing some obstruction, RVOT, and there's some turbulence in LPA, and that's the arch view. Next slide, please. So the CT scan, we look for the landing zone. There's a landing zone at the point of obstruction, and looking at the landing zone is about an average of 22 on CT scan. We go with the CT scan to screen and to see whether it is suitable for a valve implantation. There we can see is 22, which is within the range for a valve which is about up to 32. 30 we can go. And one more thing, important thing is looking at the bifurcation length from the bifurcation to landing zone is more than 2.5. So those things should be there. If you have that, then you can go for implantation. 2 parameters. Next thing, please.
Muthu, I have a question for you.
Yeah.
What was the gradient across the right ventricular outflow tract on Doppler?
Doppler 40 to 50.
40 to 50 millimeters.
So, so we did a MRI which showed RV index from 147, which is the borderline, and systolic volume is increased 91, and ejection fraction is slightly low. So, with symptoms with sort of borderline RV and obstruction, we thought there's indication to replace this valve. Next slide, please. So, the coronary anatomy is something we look for. The closest coronary artery which arises closer to the landing zone is your LAD, and you can see LAD very close. So we always wire the closest coronary, so landing zone. So the LAD has to be wired. Next slide, please. So plan, the 14-year-old boy with significant PR and RV volume overload and PS also. Symptomatic CT scan showed a good landing zone, and we're going to do a balloon sizing. We're going to protect the LAD and proceed to TPVI, pulmonary valve implantation is suitable. That's the plan.
My question, Muthu, I have a question for you. Why do you want to protect the LAD if your balloon interrogation of the coronary arteries is okay?
So actually, Bharat, what we do is we balloon size and we go 20% more than that balloon size, because there is no major constriction force here. So ultimately, we are not checking for the largest diameter. So
if you are going beyond that, then you need to check for going beyond that, because if you are going beyond that, sometimes the wire may not help. If it compresses the coronary artery, I think you should be very clear when you're interrogating the coronary artery as to you are going to use the stent of the size of the balloon and not beyond that.
Yeah. You understand that, but the difficulty we have, particularly with ATPS, is you don't have if you expand to full volume, you may not have a radial force to hold the valve. And so expanding to the fullest volume and coming back, you may embolize a stent. So what we also look for is the amount of calcification around the coronaries. Usually in ATPAs with the very widely open RVOT, you do not usually have any coronary compression unless there's a big chunk of calcium sitting next to it or something like that. Can you go to the first angio, please? But actually, my strategy of doing this case, which is something I designed myself, is I access all the groin, like left femoral artery, left femoral vein, right femoral artery, right femoral vein. So we started off with right femoral vein is the one I use for implantation of the valve. And then right femoral artery is for putting the pacing catheter in LV. Why I use the pacing catheter in LV here is pacing is a very crucial point of this deployment of this valve, because the valve should not move. So I tend to push in LV. Sometimes when you had it in RV, when taking the big sheath across, it will pull this entire thing off. So I always have a LV pacing catheter. Right left femoral artery is for coronary cannulation, and the other one, left femoral vein is for your right ventricle injection, for looking for the sealing of the RV when we have balloon dilatation. Can you show the first angio, please, fluoro? Can you go to first fluoro?
I have a question
Yeah.
for you, Muthu.
Yeah.
Are you pacing from the
LV.
left ventricle or
Yeah.
from the right ventricle?
LV.
You are pacing from the LV.
Yeah. I maintain the ACT around 250, more than 250 or 300. Okay, can you place the fluoro?
My question to you is, why don't you pre-scan?
There's no need actually, Bharat. I don't think, we have number one, I'm telling you what the difficulty we have pre-stenting. If you want to pre-stent, you have to use a 28 balloon. 28 balloon means you have to use a big sheath. Big sheath means around a 28 balloon goes through a 14 or 16 French sheath. A stent over that, you have to have 22 French to take across. And we always have difficulty getting a sheath which is more than 18 French in India, but that's not the problem. But I'm just thinking, without pre-stenting we can do, then why should we pre-stent? That's my point.
So the acute results have been good so far with our experience, but we need to have long-term follow-up of these patients, because we don't know how these stents behave over long-term, whether any fractures or that we need to know. But acute results have been very good consistently.
Okay, now actually we have a sheath custom made by the MyValve company, which is a Python sheath for particularly pulmonary valve implantation, which has got a 14 to 24 configuration, and it's got a dilator which is got three ports in the dilator. So you can use up to 3 wires inside. At a time you can use 2 wires for stability. So what we felt is, whenever we taking the BISH, these valves are not customized to take across the RVOT, and more often we have difficulty in taking this valve. Sometimes they stuck on the RVOT or into one of the RV muscle, and it's difficult to take across. And so we are thinking of having a big sheath which can go into RVOTs and into the pulmonary valve position, so that we don't need to really have to cross the tricuspid valve. And this is a valve which is it's a sheath which has got good flexibility, and so we can use this. We are first time using this sheath in this patient, and we got 2 wires. Show the fluoro, please. First fluoro. First, yeah. So we do the angiograms in RAO 3030, and you can see there is a narrowing at the just supravalvular, and that's not the position we want to implant, because we know there's a small muscle, a tissue which is flopping up, and if you want to implant there, valve will embolize. So we want to have a implantation just below that. So that's the injection I do, RAO 3030, and then like a supravalvular sort of a ridge-like appearance. That's the tissue which is sort of put by the surgeon. Next slide, please. Next. So that's a lateral view. So basically, you have a narrowing, which is, I don't think I would want to rely on this narrowing. I would want to balloon dilate and put a valve, because it's not going to really support me. So next, please. So always cross the tricuspid valve with pigtail, because you would have problems in getting into tracheal apparatus. And then I always position my wire deep inside LPA. I have a strategy. Go to that strategy we had. We have 2 wire technique. So I go. Next slide, please. Next. Yeah, you can see that initially a Judkins. Then I take a stiff wire inside. Through this, I take the sound French guide. Next slide, please. Then when the sound French guide is there, then we can next. Go. Final. So you can see that through this one we push the Lundagus wire. The 2 wire technique. If you take the wire without support, the whole system comes off. Once you are anchored deep in the LPA, you have got good position. Then you can go take the valve inside. So that's it. We have got the wire across. Next, please. So we access the coronary LAD wired. Next. So we're going to implant this valve in RAO 3030. That's a view which showed nicely the narrowing. So we did an angio to make sure the LAD is seen clearly here. Next one, please. Next. Next. So the balloon is across now. We are balloon. You can see a tight vase appearing. I really don't want to deploy the valve there. And now we can see one more vase happening there, and that's the vase we have to go for. And you can see there is no seepage of dye across the complete sealing of RVOT. So we don't want to have that sort of a tight. It was like tight before we started off, and you can see there's a good sealing at that point. So next please. So we checked in both views to check for our lateral also and also in your AP view to making sure we sealing properly. So now the injection shows good LED flow, and also there is good sealing. You can see that there is no fault flow, and we are all ready to implant the valve.
My concern is that when you do this rapid ventricular pacing, you take away the pulsatility of the right ventricular outflow tract.
Okay.
And your cardiac output is so low that not the contrast not going across. I am not sure what it means, and I am not even sure that you are really interrogating the RVOT when you are pacing it at this rate.
But the thing is, there is no tricuspid regurgitation. We are injecting dye at a higher rate, like 20-20. So you can see there is no seepage. This is what we do, and usually.
I agree with you that there is no seepage,
but Dr.
Are
Bharat.
you telling me, Muthu, that with this pacing, that RVOT is really pulsatile?
No, you agree with your point, Dr. Bharat, but again, it is all collaborative. Absolutely, your point is well taken. We are collaborating the findings from the CT and looking at the waste, as well as in addition to that, we use this.
I would like to have other people's opinion on this.
I think the downside of not pacing is you will not get a good seal, the balloon will keep on going back and forth,
Yes.
you will never have the right size. We have done that and it is a problem actually. Balloon doesn't stay there at all. You try however much you try, unless you do a rapid pacing, it is just not possible to get the right diameter. Yeah, I think, see, from whatever experience we have of assessing the RVOTs without pacing, more than a dozen cases, all of them had big RVOTs, all of them were native ICRs with taps, and we couldn't hold the balloon there, whatever we tried, and they were all very big.
Muthu,
Yes.
Bharat and Suresh, may I share my idea? I'm not sure whether, again, sorry for that, what is the balloon, what is the name of the balloon, please? Z-Med.
Yeah.
Okay. I normally will not do pacing while interrogating this area, and the reason is because I try to make sure that I'm not reduce the expansibility of that area. So that's my practice. But anyhow, you see the waist. And that waist is, I think, is quite good because that would be the landing zone. So this balloon is 30 millimeter, right?
Yes, 30 mm. Yes. No, we are taking sheet
so
off.
that should be okay for 32. Because I think the waist is somehow is not moving at all. I mean, it's very fixed. So I definitely will rely on that waist, to land the valve. I personally will not. But I may choose 32 millimeter as we plan to do with my valve. Thank you.
Alright, so we are taking the sheath across now, the one I told you, the Python sheath, the long one. Yeah, we are coming to the sheath, Bharat.
Yeah, great.
So hold the sheath. Hold wire. It's okay, sir. I think it's okay there.
Yeah, looks good.
Okay, fine. Come this side. Hold the sheath, sir. Take the electro off. So I'll take the electro off. You hold the sheath. So actually, we have two wires across now with the sheath. So we thought of taking the valve with the two wires inside because this it has to act as a buddy wire to support the system, so that it doesn't straightens up. Once we into landing zone, we won't take the other wire off.
We expect that the valve will go in spite of the buddy wire inside the Python sheath. Let's see, otherwise we will again always take the wire out, but it will help us to track the valve nicely.
So the valve, my valve, I think, it comes from 20 to 32 with 1.5 mm increment, Bharat. So we've been, if you look at the ATPAs, our average is about 27.5. So it's more towards the higher side. If you look at a conduit, we are used around from 23, 24.5. That's a most in conduit. So, since we have this leeway of 32, it's much more easier for if you have a landing zone 29. The maximum landing zone we have got narrow is the 30 mm, where we went to 10 ml oversizing of this my valve, and we went there and deployed it, and it sat well. Although there was a mild PR post, since the PR, the pulmonary diastolic is low, we didn't get to see a PR and it's in follow up. So what we have a cutoff now is 30 mm is a cutoff for stable deployment.
Yeah,
now we have the valve here. So
have you made the measurement, Muthu? All the measurements have been made?
Yes, 22 and 23 is what we measured on the narrow.
If you can show that.
Can you show the measurements, please? Hold both wires, please. Hold both wires. I want to hold both wires. Somebody help Dr. Sangatuvelu.
Just 1 minute, Muthu. Just wait.
Okay, ready? Ready? Okay, fine. Let me push it.
Wait.
Hold the wires, please.
Yes, sir. Holding the wire.
Okay, going in.
Valve is
Yeah,
approaching.
yeah. Now you can push it out.
Can take the pusher out.
Okay.
Yeah.
Right, coming the valve.
Sir, I'm holding the wire. You can go ahead. You follow the.
Okay, ready?
Okay.
Ready the injection, guys?
Wait, we take the wire out, the other wire out.
You go up, sir.
Just go up and then we take the wire out.
Okay, we are across. Other wire out, please.
So, this is important not to forget this.
Coming, sir.
Take this
Both
wire
are coming in.
out. Pardon?
I'll push the other wire inside. Other wire
Push that wire.
is jammed.
No, it's coming. It's coming. Yeah.
Push the other wire inside. Okay, fine.
Out.
But the other wire should be inside. Somebody turn it around.
Yes.
Say in the watch side. Say it, sir. Okay, fine. So let's do an injection. I think I'm across, sir. Landing zone. I'm going to push it a bit further.
Okay. You check it.
Okay. Little angiogram.
I think, see, we had that second marker wire.
Okay, ready?
Injection.
It'll go up a bit more.
Little bit go up. That's enough.
Okay. One more injection, please. Ready? Okay, I think you're okay. Bit more up, sir.
Slightly more up.
Holding wire.
Yeah, I'm holding the wire. I'm pushing the wire.
Yeah.
No, go to more. You do one thing. I'll slightly give a slight pull.
Yeah, pull back.
I'm pulling slightly. Push it. Okay. Okay, I think it's moved a little bit. No.
I'm going to sheath across inside, sir. Support this catheter.
Yeah, it's meant
Yeah, okay.
better.
Okay, now do injection, please.
It looks good actually. Position.
Okay, fine. I think happy. Thambi, ready, sir? You are ready, sir? Start pacing. You do. All right. Start pacing, please. Okay. 250, yeah?
Yes, sir, 250, sir.
Inject. Inject. Inflate, Varda.
Inflate.
Inflate. Inject.
Inflate.
Inflate, Varda. Fight.
Inflate fully.
More, fully.
1,000,
fully.
3,000, 4,000.
Full, pole.
No full, sir.
Okay. Okay, deflate. Stop pacing. Okay. Take the bulb. Take bulb now, sir.
Yeah.
Okay. All right. Okay. Okay, that's the result, guys.
Great, nice.
Good result. Good result. Very stable valve. Good result. Okay, congratulations.
Congratulations.
Good result.
Excellent.
That's the echo, guys. See the valve clearly. There's trivial PR, well opposed leaflets, and show the PAs, branch PAs, short axis, guys. So it's a very nicely placed valve, and you can see there's a valve now in the RBOT. Can you see the pictures?
Yeah.
Yes,
So-
yes.
Thanks, Muthu, for that excellent demonstration.